My name is Neale Mahoney. I'm a health economist and a professor of economics at Stanford University.
So what are you focused on in your brief?
So we're studying a institution called long-term care hospitals or long-term acute care hospitals. They're a uniquely American healthcare institution. We became interested in them based on some investigative journalism in the New York Times that was documenting the payments that they received if they retained patients to a certain number of days. And so based upon that reporting and then some initial research, we decided to embark on a study of sort of what are these institutions, how do they contribute to cost and the quality of healthcare delivery in the post-acute care sector.
So tell me what you found in your research.
So the headline finding is that these long-term care hospitals, or LTACs, increase healthcare spending by approximately $4 billion a year without any measurable impacts on a number of measures of quality. And so that leads us to, I think, making probably the strongest statement that we've ever made in a research paper and calling these institutions wasteful.
So what's the policy that you're recommending?
So to think about our policy suggestions, it's useful for me to give you a little bit of background on post-acute care. And so most patients, when they have a hospitalization and are discharged for post-acute care, they go to a skilled nursing facility. But a small fraction of patients go to the long-term care hospitals that we study. And at these long-term care hospitals, Medicare pays about $1,000 more per day. And so what we're doing in our paper is examining whether these patients receive better care as a result, and they don't on any measurable dimension. And so what we propose is that Medicare switches to just paying these long-term care hospitals the same amount they pay SNFs or skilled nursing facilities. That will achieve large savings and won't generate any health effects that we have been able to detect.
So tell me about the origins of LTACs. Are these uniquely American? Do we see them in other countries? How did they come about?
Right, so LTACs, I think, arose, I think it's fair to say, by historical accident. So in the early 1980s, they were designing a large payment reform for hospitals in the United States. And they realized that this payment reform, PPS, which was going to pay hospitals a lump sum amount for every patient stay, was not well designed for a small number of hospitals that treated patients that had very long hospital stays, right? If you pay them a fixed amount and patients end up staying 20, 30, 50 days, then you're not going to be able to make ends meet. And so what Medicare did in rolling out the prospective payment system was to create a carve-out for these long-term care hospitals. At the time, there was a couple dozen of these institutions, but you create a carve-out where you pay these hospitals basically a daily amount. And lo and behold, we saw a massive entry of this type of facility. And today we have more than 400 long-term care hospitals, largely because of this carve-out that was built into the legislation in the early 1980s.
If we ended this historical quirk, if we put in place the policies that you're recommending, what sort of savings are we talking about to the Medicare system?
Right. So let me start by just talking a little bit about post-acute care. So post-acute care, we spend roughly $60 billion on post-acute care per year, which is actually very similar to the amount that Medicare Part D spends on prescription drugs. But post-acute care, I think, has received less attention from researchers and maybe from policymakers as well. A really remarkable fact about post-acute care, there's been a lot of concern about geographic variation in healthcare spending. Post-acute care, it's about 16% of spending overall, accounts for over 70% of the geographic variation. So if we think about geographic variation as an indicator of waste, then that indicator is pointing to post-acute care as the major contributor of geographic variation and therefore waste. So LTACs are a quantitatively important part of the post-acute care landscape. And we estimate if you basically close this loophole and instead of paying LTACs in this sort of ad hoc manner, but you paid them the same amount that you pay skilled nursing facilities, that you could achieve savings of roughly $4 billion per year. So adds up to real money sort of over the 10-year window.